Welcome to Pediatric Case Review. Today's lecture covers pseudohypoparathyroidism, a rare endocrine disorder crucial for pediatric and internal medicine residents. We will explore clinical presentation, diagnostic approaches, pathophysiology, and management strategies. This comprehensive review will enhance your ability to recognize and treat this condition effectively. Let's begin our clinical journey. An 8-year-old girl presents with short stature and obesity. She has a round face and short fourth metacarpals. Laboratory tests show calcium 7.2 milligrams per deciliter with elevated parathyroid hormone. What is the most likely diagnosis? Option A, primary hypoparathyroidism. Option B, pseudohypoparathyroidism type 1A. Option C, vitamin D deficiency. Option D, chronic kidney disease. The correct answer is B, pseudohypoparathyroidism type 1A. This condition features parathyroid hormone resistance combined with Albright hereditary osteodystrophy. Patients demonstrate hypocalcemia despite elevated parathyroid hormone, creating a paradoxical laboratory picture. The shortened fourth metacarpals, known as Archibald sign, are pathognomonic. This results from mutations in the GNAS1 gene, causing end organ resistance to parathyroid hormone. Physical features distinguish it from other hypocalcemic disorders. What is the primary molecular defect in pseudohypoparathyroidism type 1A? Option A, parathyroid hormone synthesis defect. Option B, parathyroid hormone receptor mutation. Option C, G-protein alpha subunit deficiency. Option D, calcium sensing receptor activation. Consider the mechanism of hormone resistance. The correct answer is C, G-protein alpha subunit deficiency. Mutations in GNAS1 reduce GS-alpha activity by 50%, impairing cyclic AMP signaling. This defect causes resistance to multiple hormones including parathyroid hormone, thyroid-stimulating hormone, and gonadotropins. The G protein normally couples hormone receptors to adenylyl cyclase. Without adequate GS-alpha, hormones cannot activate their target cells despite normal receptors, explaining the multi-hormone resistance pattern. Which clinical feature is not part of Albright hereditary osteodystrophy? Option A, brachydactyly. Option B, subcutaneous ossifications. Option C, tall stature. Option D, round face. Think about the characteristic physical phenotype associated with this genetic syndrome. The correct answer is C, tall stature. Patients with Albright hereditary osteodystrophy characteristically have short stature, not tall stature. Classic features include round facies, short stature, obesity, and brachydactyly affecting especially the fourth and fifth digits. Subcutaneous ossifications occur in soft tissues. Patients may also develop dental abnormalities and varying degrees of developmental delay. This distinctive phenotype helps distinguish pseudohypoparathyroidism type 1 from other calcium disorders. In a patient with suspected pseudohypoparathyroidism, what is the best clinical test to assess for brachydactyly? Option A, measuring hand span. Option B, knuckle dimple sign. Option C, grip strength testing. Option D, wrist radiograph. Consider simple bedside examination techniques. The correct answer is B, the knuckle dimple sign. When the patient makes a fist, normal metacarpals create visible knuckles. Shortened metacarpals produce a dimple instead of a knuckle prominence. This most commonly affects the fourth and fifth metacarpals. This simple bedside test requires no equipment and quickly identifies brachydactyly. Hand radiographs confirm findings but are unnecessary for initial screening. This sign is highly specific for Albright hereditary osteodystrophy. A 10-year-old presents with round face and short fourth fingers. Calcium is 6.8 milligrams per deciliter, phosphorus 6.5 milligrams per deciliter, and parathyroid hormone 150 picograms per milliliter. What is the expected urinary cyclic AMP response to exogenous parathyroid hormone administration? Option A, normal increase. Option B, blunted response. Option C, absent response. Option D, excessive increase. The correct answer is B, blunted urinary cyclic AMP response. The Ellsworth-Howard test involves administering parathyroid hormone and measuring urinary cyclic AMP and phosphate excretion. In pseudohypoparathyroidism type 1A, both responses are blunted due to G-protein deficiency preventing cyclic AMP generation. Type 1B shows similar blunting but isolated parathyroid hormone resistance. Type 2 demonstrates normal cyclic AMP but impaired phosphaturic response, suggesting post-receptor defects. This test distinguishes pseudohypoparathyroidism subtypes. A 12-year-old with pseudohypoparathyroidism develops painful subcutaneous nodules. What is the most likely composition of these nodules? Option A, lipomas. Option B, heterotopic bone formation. Option C, calcium pyrophosphate crystals. Option D, gouty tophi. Consider complications specific to this disorder. The correct answer is B, heterotopic bone formation. Subcutaneous ossifications occur in Albright hereditary osteodystrophy due to GS-alpha deficiency affecting mesenchymal cell differentiation. Ectopic bone forms in subcutaneous tissues and muscles, appearing as hard, palpable nodules. These ossifications may cause pain and limited mobility. Imaging reveals characteristic calcifications. Treatment is generally supportive, but symptomatic lesions may require surgical excision. This finding is pathognomonic for pseudohypoparathyroidism type 1A. How does pseudohypoparathyroidism differ from pseudohypoparathyroidism type 1A? Option A, different gene mutation. Option B, normal calcium and parathyroid hormone levels. Option C, absence of Albright hereditary osteodystrophy features. Option D, more severe brachydactyly. Consider biochemical versus phenotypic differences. The correct answer is B, normal calcium and parathyroid hormone levels. Pseudohypoparathyroidism involves the same GNAS1 mutation but inherited paternally. Patients display Albright hereditary osteodystrophy features without hormone resistance, maintaining normal biochemistry. This occurs through genomic imprinting, where GS-alpha expression is tissue-specific based on parental origin. Maternal inheritance causes hormone resistance affecting renal tubules. Paternal inheritance produces only physical features. This demonstrates how genetic imprinting influences clinical expression of identical mutations. A patient with untreated pseudohypoparathyroidism develops perioral numbness and muscle cramps. What is the most serious potential complication of worsening hypocalcemia? Option A, seizures. Option B, hypertension. Option C, hypoglycemia. Option D, thrombocytopenia. Considered neurological manifestations of severe hypocalcemia. The correct answer is A, seizures. Severe hypocalcemia increases neuronal membrane excitability, causing potentially life-threatening complications. Progressive symptoms include paresthesias, muscle cramps, tetany, and carpopedal spasm. Laryngospasm may compromise airway. Seizures represent severe hypocalcemia requiring urgent treatment. Electrocardiogram may show prolonged QT interval, increasing arrhythmia risk. Chvostek and Trousseau signs indicate latent tetany. Prompt recognition and calcium replacement prevent progression to critical neurological complications in untreated pseudohypoparathyroidism. How do you elicit the Chvostek sign? Option A, inflate blood pressure cuff above systolic pressure. Option B, tap facial nerve anterior to ear. Option C, hyperventilate for 3 minutes. Option D, flex wrist against resistance. Recall bedside examination techniques for hypocalcemia. The correct answer is B, tap the facial nerve anterior to the ear. A positive Chvostek sign produces ipsilateral facial muscle twitching, indicating neuromuscular irritability from hypocalcemia. Tap gently just anterior to the earlobe over the facial nerve. While 70% sensitive for hypocalcemia, 10% of healthy individuals show positive results. Trousseau sign is more specific. Both signs help identify latent tetany before severe symptoms develop, guiding urgent treatment decisions. What is the technique and finding for Trousseau sign? Option A, arm blood pressure cuff inflation causes hand spasm. Option B, deep tendon reflex hyperactivity. Option C, positive Babinski response. Option D, nuchal rigidity with flexion. Consider specific hypocalcemia examination techniques. The correct answer is A, blood pressure cuff inflation causes hand spasm. Inflate the cuff 20 mm mercury above systolic pressure for 3 minutes. Positive Trousseau sign produces carpopedal spasm with the hand, assuming the characteristic obstetrician's hand position, featuring flexed wrist, thumb adduction, and extended fingers. This sign is 94% specific for hypocalcemia, more reliable than Chvostek sign. A positive result indicates significant hypocalcemia requiring prompt calcium replacement therapy. Always check for both signs in suspected cases. A new patient presents with suspected pseudohypoparathyroidism. What are the essential initial laboratory tests? Option A, calcium, phosphorus, parathyroid hormone, and vitamin D. Option B, complete blood count only. Option C, liver function tests. Option D, cortisol and adrenocorticotropic hormone. Consider diagnostic confirmation requirements. The correct answer is A, calcium, phosphorus, parathyroid hormone, and vitamin D. Pseudohypoparathyroidism demonstrates low calcium, high phosphorus, and elevated parathyroid hormone, the diagnostic triad. Vitamin D assessment excludes deficiency as an alternative cause. Additional tests include magnesium, affecting parathyroid hormone secretion, creatinine evaluating renal function, and albumin for corrected calcium calculation. Thyroid-stimulating hormone identifies multi-hormone resistance. Genetic testing confirms GNAS1 mutations. This comprehensive panel establishes diagnosis and excludes differential diagnoses like primary hypoparathyroidism or vitamin D deficiency. Why does pseudohypoparathyroidism cause hyperphosphatemia? Option A, increased intestinal phosphorus absorption. Option B, impaired renal phosphorus excretion. Option C, bone phosphorus release. Option D, decreased phosphorus utilization. Consider parathyroid hormone's normal effect on phosphorus handling. The correct answer is B, impaired renal phosphorus excretion. Parathyroid hormone normally promotes renal phosphorus excretion by inhibiting proximal tubule reabsorption. In pseudohypoparathyroidism, parathyroid hormone resistance prevents this phosphaturic effect, causing phosphorus retention and hyperphosphatemia. This contrasts with primary hyperparathyroidism, where excessive parathyroid hormone causes hypophosphatemia. The combination of hypocalcemia and hyperphosphatemia with elevated parathyroid hormone distinguishes pseudohypoparathyroidism from other calcium disorders, making it a diagnostic hallmark. How does parathyroid hormone resistance affect vitamin D metabolism? Option A, increased 1,25-dihydroxyvitamin D production. Option B, decreased 1,25-dihydroxyvitamin D production. Option C, no effect on vitamin D metabolism. Option D, increased 25-hydroxyvitamin D production. Consider parathyroid hormone's role in vitamin D activation. The correct answer is B, decreased 1,25-dihydroxyvitamin D production. Parathyroid hormone normally stimulates renal 1-alpha-hydroxylase, converting 25-hydroxyvitamin D to active 1,25-dihydroxyvitamin D. Parathyroid hormone resistance impairs this enzyme activation, reducing active vitamin D production. This compounds hypocalcemia by decreasing intestinal calcium absorption. Treatment requires both calcium and calcitriol supplementation. The 25-hydroxyvitamin D level remains normal since hepatic conversion is unaffected. This explains why vitamin D supplementation alone inadequately treats pseudohypoparathyroidism. The child has confirmed pseudohypoparathyroidism type 1A. What are the expected thyroid function findings? Option A, primary hyperthyroidism. Option B, subclinical hypothyroidism. Option C, secondary hyperthyroidism. Option D, normal thyroid function. Consider the multi-hormone resistance pattern in this condition. The correct answer is B, subclinical hypothyroidism. G-protein alpha subunit deficiency affects thyroid-stimulating hormone signaling in addition to parathyroid hormone resistance. Approximately 70% of pseudohypoparathyroidism type 1A patients develop elevated thyroid-stimulating hormone with normal or slightly reduced thyroxine levels. This represents thyroid-stimulating hormone resistance at the thyroid gland. Many patients require levothyroxine replacement. Regular thyroid function monitoring is essential. This multi-hormone resistance pattern distinguishes type 1A from other pseudohypoparathyroidism subtypes lacking GS-alpha deficiency. A newly diagnosed 8-year-old with pseudohypoparathyroidism has calcium 6.5 mg per deciliter but is asymptomatic. What is the appropriate initial treatment? Option A, oral calcium and calcitriol. Option B, parathyroid hormone injections. Option C, observation only. Option D, intravenous calcium infusion. Consider appropriate therapy for chronic hypocalcemia. The correct answer is A, oral calcium and calcitriol. Standard treatment combines oral calcium supplementation providing 1 to 3 grams elemental calcium daily with calcitriol 0.25 to 2 micrograms daily. Parathyroid hormone injections are ineffective due to end-organ resistance. Treatment goals include normalizing serum calcium and controlling parathyroid hormone elevation. Intravenous calcium is reserved for symptomatic hypocalcemia or acute presentations. Regular monitoring every 3 to 6 months ensures adequate control. Thiazide diuretics may reduce urinary calcium losses, minimizing nephrocalcinosis risk. A patient has received calcitriol and calcium supplementation for 2 years. What is the most important monitoring parameter? Option A, complete blood count. Option B, urinary calcium excretion. Option C, liver enzymes. Option D, fasting glucose. Consider complications of chronic calcium and vitamin D therapy. The correct answer is B, urinary calcium excretion. Calcitriol increases intestinal calcium absorption, but parathyroid hormone resistance prevents compensatory renal calcium reabsorption, causing hypercalciuria. This predisposes to nephrocalcinosis and kidney stones, major treatment complications. Monitor urine calcium to creatinine ratio. targeting values below 0.2. Thiazide diuretics reduce urinary calcium excretion when needed. Regular renal ultrasounds detect nephrocalcinosis. Balance adequate calcium replacement against hypercalciuria risk. This monitoring prevents long-term renal complications while maintaining calcium homeostasis. What factor most affects final adult height in pseudohypoparathyroidism? Option A, calcium level control. Option B, early growth hormone therapy. Option C, genetic skeletal dysplasia. Option D, thyroid hormone replacement. Consider intrinsic growth limitations versus treatable factors. The correct answer is C, genetic skeletal dysplasia. Short stature in pseudohypoparathyroidism results from intrinsic skeletal dysplasia caused by GNAS1 mutations affecting bone development. Average adult height ranges from 150 to 155 centimeters. Premature growth plate closure is common. Growth hormone therapy provides minimal benefit since short stature is not growth hormone deficient. Optimal calcium and thyroid hormone replacement prevent additional growth impairment. Families need counseling about realistic height expectations. Focus treatment on metabolic control rather than height augmentation. What is the prevalence of intellectual disability in pseudohypoparathyroidism type 1A? Option A, rare, less than 10%. Option B, mild disability in 75%. Option C, severe disability in most. Option D, no increased risk. Consider neurodevelopmental manifestations. The correct answer is B, mild intellectual disability occurs in approximately 75%. Cognitive impairment in pseudohypoparathyroidism type 1 typically ranges from mild to moderate severity. Learning difficulties are common, including attention deficit hyperactivity disorder and developmental delays. Severe intellectual disability remains uncommon. G protein signaling affects brain development and function. Early educational intervention, special education support, and developmental monitoring optimize outcomes. Regular neurodevelopmental assessments guide appropriate support services. This emphasizes importance of comprehensive multidisciplinary care beyond metabolic management. What is the primary mechanism of obesity in pseudohypoparathyroidism type 1A? Option A, hypothalamic leptin resistance. Option B, reduced metabolic rate. Option C, hyperphagia from calcium imbalance. Option D, corticosteroid excess. Consider hormonal resistance mechanisms beyond calcium homeostasis. The correct answer is A, hypothalamic leptin resistance. G-protein alpha subunit deficiency impairs hypothalamic leptin signaling, affecting satiety and energy expenditure regulation. Approximately 90% of pseudohypoparathyroidism type 1A patients develop obesity, often beginning in early childhood. This represents true hormonal obesity, not simply behavioral factors. Nevertheless, lifestyle modifications including diet counseling and exercise programs remain essential. Early nutritional intervention may limit weight gain. Obesity compounds cardiovascular risk and complicates metabolic management, requiring aggressive multidisciplinary intervention. A patient with long-standing untreated pseudohypoparathyroidism has brain-computed tomography showing bilateral basal ganglia calcifications. What is the clinical significance? Option A, requires immediate neurosurgery. Option B, associated with movement disorders. Option C, indicates brain tumor. Option D, normal aging change. Consider chronic hypocalcemia complications. The correct answer is B, associated with movement disorders. Chronic hypocalcemia causes calcium phosphate deposition in basal ganglia and cerebellum. These calcifications may produce Parkinsonism, dystonia, or chorea, though many patients remain asymptomatic. Neurological symptoms correlate with calcification severity and location. Adequate calcium control prevents progression but rarely reverses established calcifications. Symptomatic movement disorders may require neurological treatment. Regular brain imaging is unnecessary if calcium well controlled. This emphasizes importance of early diagnosis and consistent treatment preventing irreversible neurological complications. What is the mechanism of cataract formation in pseudohypoparathyroidism? Option A, direct GNAS1 mutation effect on lens. Option B, chronic hypocalcemia causing lens calcium deposits. Option C, increased intraocular pressure. Option D, vitamin D deficiency effect. Consider effects of chronic calcium disturbance. The correct answer is B, chronic hypocalcemia causing lens calcium deposits. Prolonged hypocalcemia disrupts lens epithelial metabolism, promoting calcium phosphate crystal deposition in the lens capsule and cortex. Cataracts typically develop in posterior subcapsular regions. They may impair vision, requiring surgical extraction if significant. Early diagnosis and consistent calcium replacement prevent cataract development. Regular ophthalmologic screening detects early changes. This complication emphasizes long-term consequences of inadequate metabolic control. Optimal calcium management from diagnosis prevents irreversible, vision-threatening complications. What are common dental findings in pseudohypoparathyroidism patients? Option A, supernumerary teeth. Option B, delayed tooth eruption and enamel hypoplasia. Option C, accelerated tooth development. Option D, increased cavity resistance. Consider calcium's role in dental development. The correct answer is B, delayed tooth eruption and enamel hypoplasia. Calcium is essential for normal dental development. Pseudohypoparathyroidism patients commonly experience delayed tooth eruption, enamel hypoplasia, and shortened tooth roots. These abnormalities increase susceptibility to dental caries. Regular dental examinations and preventive care are crucial. Fluoride treatments and careful oral hygiene help prevent complications. Orthodontic consultation may address malocclusion from skeletal abnormalities. Comprehensive dental care is integral to overall management. Emphasize preventive strategies with families to maintain oral health throughout life. Pseudohypoparathyroidism type 1b differs from type 1a by which characteristic? Option A, worse hypocalcemia. Option B, absence of Albright hereditary osteodystrophy features. Option C, paternal inheritance. Option D, no parathyroid hormone resistance. Consider phenotypic versus biochemical differences between subtypes. The correct answer is B, absence of Albright hereditary osteodystrophy features. Pseudohypoparathyroidism type 1b demonstrates isolated parathyroid hormone resistance without the physical phenotype. This results from GNAS imprinting defects rather than coding sequence mutations. Patients maintain normal stature, facial features, and intelligence. Multi-hormone resistance is typically absent. Biochemical findings mirror type 1a with hypocalcemia, hyperphosphatemia, and elevated parathyroid hormone. Treatment approaches are similar, but prognosis for growth and development is more favorable without Albright hereditary osteodystrophy features. What is the defining characteristic of pseudohypoparathyroidism type 2? Option A, complete absence of parathyroid hormone. Option B, normal cyclic AMP response, impaired phosphaturic response. Option C, excess parathyroid hormone secretion. Option D, elevated cyclic AMP with normal phosphate. Consider post-receptor signaling defects. The correct answer is B, normal cyclic AMP response with impaired phosphaturic response. Pseudohypoparathyroidism type 2 has defects downstream from cyclic AMP generation. Parathyroid hormone successfully produces cyclic AMP but fails to trigger phosphate excretion. This extremely rare subtype suggests post-cyclic AMP signaling abnormalities. Patients lack Albright hereditary osteodystrophy features. Biochemical findings resemble other types with hypocalcemia and elevated parathyroid hormone. The Ellsworth-Howard test distinguishes type 2 from type 1. Treatment principles remain similar despite different molecular mechanisms. A patient presents with hypocalcemia, hyperphosphatemia, and elevated parathyroid hormone, plus round face and short stature. What key finding best distinguishes pseudohypoparathyroidism from vitamin D deficiency? Option A, hyperphosphatemia. Option B, elevated parathyroid hormone. Option C, physical phenotype. Option D, age of onset. Consider biochemical and phenotypic differences.